The following podcast is part of a certified educational activity titled Navigating Evolving Standards of Care in Renal Cell Carcinoma. Expert insights on selecting and sequencing targeted and immunotherapy options, and a look at emerging strategies. Access the entire activity and complete the post-test at peerview.com/TRX860. Downloadable slides and practice aids are also available.
Well, welcome everyone. So great to see everyone here in person and certainly online at ASCO GU 22. I think we're going to have a great conversation today around evolving standards in kidney cancer therapy. Now, David and I have actually done this several times before. We've never seen an audience this big, so Tian, I think the credit goes to you. So thank you. Thank you for that, Tian. But we have a packed agenda tonight. I think many of you are familiar with a bunch of David's work, Tian's work. We really want to thank PeerView and the Medical Learning Institute and Casey Cure, who has a really unique contribution to tonight's program for what they've done in terms of putting this program together. And we're going to jump right into the content. So we decided to take an approach in which we are going to focus on a couple of different concepts. If you focus your attention on the right-hand side, we'll discuss some of the new advances in the frontline and perioperative setting for renal cell carcinoma. And the second portion will take you on a walk through some of the recent updates in terms of data for frontline therapy of RCC. And then we'll conclude discussing novel approaches and the approach to the refractory patient. So just for a little context here, we're going to start with a case. And this is something that I think that the three of us are pretty used to seeing in clinic. A 58-year-old gentleman who presents with nausea, vomiting, fatigue, and weight loss. He has an abdominal CT that shows a 10-centimeter mass, and he undergoes a partial left nephrectomy. This is a 10.4-centimeter tumor with distal renal vein involvement, negative margins, grade 3, no sarcomatoid or rhabdoid features, clear cell histology dominant. You get the staging back, and on the report it reads pathologic T2N1. This patient recovers well. Post-surgical imaging is clear. We're going to get into some of the data in just a second, but quick one-sentence answer for what you do in this case, David?
Sorry, from taking out the tumor?
In terms of adjuvant therapy, what do you think,
yes.
surveillance or
Okay,
adjuvant?
Yeah, I would start with having someone else take out the tumor.
Thank God. Okay, you're a medical oncologist.
And then, I think the way the data is looking, and we'll get an update again at this meeting, which we're looking forward to, we're probably offering this patient immune therapy with pembrolizumab in the adjuvant setting, with the caveats that, the data is set as early. We see certainly improvements in disease-free survival, which we'll talk about, and a trend towards overall survival improvements, which is encouraging. So we're certainly having that conversation with the patient, also balancing it with the side effects that sometimes can be lifelong. So it's a good conversation to have with the patient.
It's a great sneak peek, and we'll get back to this case in just a second, but I want to turn it over to Tian to discuss the landscape of perioperative therapy with us. Tian?
Great, thank you so much, Monty. All right, let's get started here. So as we were hearing, localized disease is very much a surgical problem, and our urologists are often offering surgery for locally advanced disease that is resectable. There's, while we have quite a few neoadjuvant strategies for patients with other solid tumors, there really haven't been advances in perioperative systemic therapies for renal cell carcinoma in terms of neoadjuvant prior to surgery. But nephrectomy itself can certainly offer great advances in terms of a cure in early localized disease. But for stage 2 and stage 3 kidney cancers, the risk of recurrence is certainly not zero. And so how do we talk about this with our patients, with 20 to 40% of them experiencing a local or distant recurrence within a 2 to 5 year period? So currently there's no approved preoperative therapies for locally advanced disease, although we're certainly thinking about it as patients are going to their nephrectomy and the next steps. So we're going to talk through how we decide in the post-operative setting what patients might be amenable to, so two approved therapies in the post-op setting. I just highlight here for you a number of phase 2 clinical trials in the neoadjuvant setting. There's 5 that are ongoing. The neo-AVAX, I would draw your attention to the middle of the slide, where Dr. Axel Becks will be presenting the data from axitinib and avelumab given in the preoperative neoadjuvant setting for non-metastatic clear cell kidney cancer on Saturday. So that's an important study to look forward to. But multiple studies ongoing and many that will combine our TKIs and immunotherapies with great effect in early preoperative settings. And we certainly look forward to all of these data coming forward in the next few years. So as we go into the adjuvant setting and post-op, so our patient had undergone his surgery and we're thinking through his risk of recurrence and thinking about benefit versus risk in terms of giving adjuvant therapy. So what are we having those discussions around benefit versus risk? And so the benefit certainly is around potentially preventing disease recurrence and hopefully by doing that, prolonging their overall survival. But what are the risks in terms of toxicities of treatment, cost implications, and the inconveniences of coming to treatment into the medical center? So in 2017, we did have an FDA approval of adjuvant sunitinib in this setting based on the results of STRAC, which was positive for improving disease-free survival outcomes. But in terms of treatment with a year of sunitinib in the adjuvant setting, it had pretty significant toxicities with the usual TKI toxicities of hypertension and hand-foot syndrome. And the inconvenience and cost of treatment for the year usually in our real-world practices was not widely adopted. And if and when it was recommended, adjuvant sunitinib was usually given for younger patients who may experience higher anxiety levels about disease recurrence and could handle the toxicities for a year. And remember, in this adjuvant setting, we're talking about patients who have had their tumors removed and otherwise have recovered well and are otherwise not very symptomatic at baseline. So what are our phase 3 adjuvant trials with checkpoint inhibitors now that we're in the checkpoint inhibitor era? We list them here for you on the side. There are 5 of them total. We've seen some results of Emotion 010 and then Keynote 564 we'd like to highlight for you tonight. Prosper fully accrued. It was a perioperative study of nivolumab given 1 dose before surgery and then followed by postoperative nivolumab, and that fully accrued within the cooperative groups last August, so we're awaiting data from that. And then the Rampart and Checkmate 914 studies are currently ongoing. So as we saw at ASCO in 2021, Dr. Shreri and his colleagues presented the data from the phase 3 Keynote 564 study. Many of you are familiar with this data now, showing the randomization between pembrolizumab and placebo given for a year in this context, improved median disease-free survival rates. Here you see the Kaplan-Meier curve on the left. With a median follow-up at that point of 24 months, we saw a hazard ratio of 0.68, which was statistically significant. And there was a trend toward improvement in overall survival, although not enough events had occurred so that we could see a clinically meaningful difference. And as we looked at safety and quality of life within patients who were treated with pembrolizumab for a year, we saw the usual immunotherapy-mediated toxicities, rashes, colitis, endocrinopathies, et cetera. About 20% of which led to discontinuation of pembrolizumab during the year. And these safety results were certainly in line with our expected side effects of pembrolizumab for a year, and no new safety signals were observed. There were some quality of life measures that were presented also, comparing patients treated with pembrolizumab or placebo, and these were very similar in terms of symptom burden. So in terms of thinking about pembrolizumab, in November of 2021, we received an FDA label of treatment with pembrolizumab for adjuvant treatment of patients with kidney cancer with intermediate or high risk of recurrence following nephrectomy. And this really, I think, depends on patient preferences and priorities as we have these discussions in our everyday practice. We're certainly still thinking about this risk-benefit ratio. I think the grade 3 and higher toxicities is lower. It is extending our time until disease recurrence for sure. There's a question around whether it extends overall survival in the longer-term follow-up. Severe toxicities, though, when we talk about these treatments with patients, the severe immune-mediated toxicities currently can be life-threatening and life-altering over many months and even lifelong. There's a cost certainly to patients and payers in this health system, and IV treatments are given every 3 or every 6 weeks, and certainly there's an inconvenience of coming back and forth to the cancer centers. So I think it's all dependent on discussion with patients about their preferences and priorities, their tolerances for toxicity, and the goals for treatment and shared decision-making. And of note, on Saturday, we will see the updated abstracts of the 30-month follow-up of Keynote 564, where Dr. Choueiri will present during the oral presentation section of the Renal Day, and we'll see that in the abstract currently, the 30-month follow-up for disease-free survival has still maintained with a hazard ratio of 0.63. So just reminding people of the ongoing studies in this adjuvant space. The Checkmate 914 study is still currently open and enrolling patients post-resection in the post-op setting and randomizing patients to either nivolumab with ipilimumab doublet or nivolumab alone or placebo. The PROSPER study I mentioned earlier has fully accrued through the cooperative groups in August of last year. This was a perioperative study where patients received 1 dose of nivolumab before surgery and then adjuvant nivolumab for up to a year, or surgery alone on the standard of care portion of the study. So I hope we will see the effects of PROSPER and the data from PROSPER in the year or two to come. So how about patients? What do patients care about when they're thinking through adjuvant therapy? And this is a really unique take and survey level data collected from KC Cure and our friends there. And they asked this question of, if you were able to receive treatment to prevent recurrence of kidney cancer, what would be important for our patients? And so obviously many of them care about improving time until death, right? Improving overall survival. And a significant portion also care about prolonged disease-free survival and delaying time until recurrence. Interestingly, I thought that fewer percentage, 43% of these patients cared about the toxicity of the treatment, and then a fewer percentage still, 37% cared about whether insurance covered or not these treatments. And so patients are willing to use adjuvant therapy if the treatment prolongs overall or disease-free survival, and toxicity of the treatments is perhaps less important to patients rather than the efficacy endpoints. In terms of fear of cancer recurrence, they also asked the question of whether the patients are in this anxiety level of, we hear a lot about scan anxiety and patients' well-being during time since diagnosis and as they're being followed along over interval scans. And so patients with distress as you look across time on the bottom on the x-axis, as time goes by and as emotional well-being actually decreases in terms of distress. As patients get their initial scans, they're at heightened awareness and heightened anxiety, and as time goes on, that level of distress decreases. But we should certainly be aware of these patient perspectives and how patients will interact as they approach and value this risk and benefit analysis. So we're back to the case, and I'll turn it back over to Monty.
That was a great overview, Tian. Fantastic slides and really nice landscape picture that you gave us for perioperative therapy. So we're going to get back to this case, and maybe Tian, David offered an opinion right at the outset regarding how he'd manage this T2N1 patient with clear cell histology, no sarcomatoid or rhabdoid features. Any thoughts? Are you leaning the same way?
Sure, yeah. I mean, this patient had 1 out of 5 lymph nodes that were positive, so I take that with a measure of degree of risk of disease recurrence. I often go into the Assure nomogram online. Fox Chase has a wonderful website to look at risk of disease recurrence based on pathologic features and patient features. And so I use those numbers to help guide the discussion, and I think with nodal positivity, this patient probably has a decent amount of risk to recur, and so I would think about offering adjuvant pembrolizumab and talk him through the risks and benefits.
That makes sense to me. So, David knows this. I like to throw in some zingers here, totally unplanned, okay? So David, what if this patient actually had a pure papillary tumor? No sarcomatoid features, no clear cell features. Would you offer this patient adjuvant therapy then?
Well, it's a data-free zone, so I can pretty much say whatever I want to say at this point.
Sure.
So the short answer is we don't know. What we do know is that pembrolizumab, at least in Keynote 427, was active in papillary kidney cancer, with the response rate in the metastatic setting being about 25%. So you might be able to extrapolate that to a clear cell, to an adjuvant setting, and say there's probably some activity here. Exactly how much is hard until we enroll more patients with papillary kidney cancer on these trials, which we obviously should do because they represent maybe upwards of 15 or 20% of our patients, and they often present with nodal involvement. Non-clear cell tumors tend to spread to the nodes in some ways more than clear cell. So it's an important question. We need more data, but it's certainly something you could consider in the motivated patient.
And what would you do? Can you give us a yes or no on this one? What do you think?
Well, I would certainly offer it, but it's a balanced discussion, and you cannot say, I know this is going to be helpful, and it could be harmful. A lot of it has to do with the patient's willingness to accept a certain amount of risk. So if they said, I'm motivated, I want to try it, you certainly can try it. So I would certainly offer it.
Okay, that's totally fair. So I have another zinger for you, Tian, if that's okay. So, just imagine this being a patient with a 6.5 centimeter tumor. So this is pathologic T1B, okay? Let's say there's no sarcomatoid features. Let's say it's grade 3, okay? Node negative. Would you offer this patient adjuvant therapy in that scenario?
Right, and so an earlier stage tumor, smaller with less aggressive features, no nodal involvement, I think the risk for recurrence is probably 10-15%, and so then the absolute benefit of giving a year of pembrolizumab is probably less clear and smaller absolute benefit for sure. And so in that setting, we can still talk about it, and sometimes our surgeons are already talking about it and having those conversations, and if the patient's still interested, they're coming over to have more conversations in the medical oncology setting. Personally, I feel there's probably more toxicity in those settings than benefit of early pembrolizumab in this adjuvant setting, and so I would probably dissuade the patient from a year of pembrolizumab.
So more or less a no, right? I mean, I tend to agree with that. I think that's the right approach there. And I thought I ran out of zingers, but I do have one more. David, I'm going to throw this one to you if that's okay.
Fire away.
Imagine this is a patient who's had metastasectomy now.
Yep.
So patient comes in, let's say he had his primary removed 3 years ago, okay, comes in and has 2 3-centimeter tumors removed from his lung surgically, okay, 3 years later.
Yep.
What do you think? Adjuvant pembro?
Yes, for sure. I think the chance of that person recurring again in their lifetime is 80-90%. We know PD-1's active in clear cell patients. Some of the benefit, you could say a fair chunk of the benefit we're seeing thus far in this trial is being driven by that M1 resected group. This is slightly different than that. You threw a twist in there, which is fine. You can
a zinger.
Zinger. Yes, so those M1 resected patients are doing pretty well, seeing adjuvant pembro early. So I would definitely offer. In that setting, it's probably the place where I'm most clearly advising people to get it at this point. But I think Tien brings up a lot of important points, and we've had a challenge in melanoma where PD-1 is also approved in the stage 3 setting. It was used broadly, at least initially, now is being in some ways used less in certain stage patients. And we really need better selection criteria than just these clinical criteria for identifying patients. We don't want to be putting patients at risk who are probably cured of their disease. So we need a lot more work in this space, as she suggested.
Actually, I have a couple more zingers. So let's envision this patient actually progressed after adjuvant pembrolizumab therapy. This is something that we're going to have to be dealing with pretty soon in the clinics, and it's a tough one. I really don't think there's one right answer over here. But I wanted to have a discussion around this. So let's say you put your patient in this scenario, again, T2N1, on adjuvant pembrolizumab, and what if they progress during adjuvant therapy, David, during that 1 year of treatment? What would you offer them as their frontline approach? Would you duplicate, PD-1 frontline? Would you give them Nivo-Ipi?
So until we see the results of trials like yours,
Okay.
the CONTACT-03 trial, which is looking at PD-L1 in the second-line setting and the post-PD-1 setting, right now there's zero evidence that PD-1 or PD-L1 salvages a PD-1 failure.
Okay.
Zero. So although we do it all the time in the clinic, people are giving, rotating combos in patients, but there's no data. So if patient progresses on PD-1, you could argue there's no data that PD-1 will salvage that patient, so you're moving on to something else, probably a different mechanism. I'm saying a single agent TKI is certainly a lot of data supporting that decision, but going with, say, combo-based PD-1 while failing on PD-1, you're probably not helping your patient in that setting.
That makes perfect sense to me. And what if we change this, tweak it a little bit, Tian? So this patient didn't progress while on adjuvant pembrolizumab, but instead about 6 months later. What would you do there?
That 6-month time point, I think, is a hard one to deal with. We're thinking that, are they out of the window of benefit from the initial PD-1 therapy, right? And there's some data from nivolumab-treated patients that T cells can be activated some 6 to 9 months later after their last dose. So to me, that is a tricky window. Are they really refractory or not to T cell activation and PD-1 inhibition? I would certainly have a conversation and offer our frontline treatment options at this moment, although it's hard to tell. We don't have data on, I agree with David completely that we don't have data for people who have progressed after frontline sort of adjuvant PD-1 therapy. So, but I think still it's a first-line metastatic discussion, and we can talk about all the approved therapy options. And see which one of those the patient might want to go on.
And this might be a little easier, David. What about 2 years out? I mean, is everything back on the table at that point?
Well, we need more data. So we need your Atezo, Cabo data. We need the TiVo, Nivo result. But until we have data, I think the answer to that question comes down to, do you think there's something called PD-1 deficiency? So meaning, do you think in patients who are on PD-1 and getting some benefit, stable or shrinking, that they need that chronic blockade? There may, we don't really know the answer to that, but the answer in some patients may be yes. Right. And so in those patients, if they needed chronic blockade, you had them under control while they were on it, you're making the argument that by reestablishing it, you're going to get that disease under control. We obviously need prospective trials, but there's at least some, as Tian was suggesting, there's at least some retrospective data that some patients who come off in response can be salvaged with, the re-addition of PD-1. So at 2 years, we're probably offering it again, I would say.
Perfect. Well, that was a tough set of scenarios there, so I appreciate you bearing with me. And I'm actually going to jump into a short discussion here on frontline treatments. In the context of this talk, we're not going to walk through all the details of every one of these 4 pivotal trials that have really shaken up the landscape of frontline treatment for metastatic renal cell carcinoma. This is a slide that I've seen, both in talks like this and all over Twitter, and they're constantly tweaked and updated. But today we'll try to add some context. We're going to discuss this case, which is a 58-year-old gentleman who actually has metastatic disease emerging and something that we would characterize as being favorable risk. You can see his laboratory parameters there. He maintains good Karnofsky performance status. And towards the end of this discussion, we'll go through and I'll ask David and Tian how they might approach a favorable risk patient like this. So again, the general design of these trials lends itself to cross-trial comparisons, although of course we're not supposed to do that. You can see here that each one of these checkpoint inhibitor plus TKI combinations has been juxtaposed against sunitinib at the same dose, 50 milligrams, 4 weeks on, 2 weeks off. And we'll go quickly through some of the updated results here. So, this is the data from Keynote 426. And when you look at the data for this, you can see that the benefit of axi-pembro still stands. We've reached median overall survival, as you can see on the left-hand side there with axi-pembro at 45 months. If you shift your attention to the right, you can see a modest benefit in terms of progression-free survival, 4 months there with axi-pembro versus sunitinib therapy. Response rates in the most recent updated data sets indicate a response rate of 60% with the combination versus 40% with sunitinib. One thing that I'll point out here is that the complete response rate appears to have climbed up a little bit to 10% in this data set. One interesting element of Keynote 426 is it gives us some understanding of how patients might do with treatment discontinuation. So these patients were allowed to discontinue checkpoint inhibitor after 2 years. And you can see here, sort of magnified on the right-hand side, the fact that there's some attrition, but not a lot. There's still some patients who really continue to have protracted benefit from therapy. Now, this is the updated data from Checkmate 9ER, and in fact, we tried to keep these slide sets very timely, but we're actually going to get another update on this data set on Saturday. We'll discuss that very briefly. But you can see here what I really sort of interpret as being, a more striking difference in terms of progression-free survival between the two treatment arms here, a median PFS of 16.6 months with cabo-nivo versus 8.3 months with sunitinib in this context. This is the Kaplan-Meier curves that reflect the data that I just showed you there. And you can see here that longer follow-up, the PFS, the OS, and the response data were sustained with cabo-nivo versus sunitinib. You can see that there's a report of the final OS hazard ratio in abstract form already. So you'll see the full data set flushed out on Saturday here. And again, consistent benefit in OS hanging with an overall survival hazard ratio of 0.7. This is a brief update on the CLEAR data set. So you can see here, with CLEAR, we see probably the highest response rate amongst the TKI-IO combos, albeit, I'll point out one of the nuances here. We're using a dose of lenvatinib at 20 milligrams. Editorial comment, I think that's a pretty challenging dose for patients to tolerate. I've become much more familiar with, and I think perhaps developed a stronger affinity for the dosing of cabozantinib at 40 milligrams in that frontline setting. Much easier, I think, for patients to tolerate. But nonetheless, you do see that this particular regimen hits a high watermark for response rate. CR rate is 16% here. And this is the overall survival data here. You can see here that median OS still wasn't reached in the treatment arm with an updated analysis, and the hazard ratio here is 0.72. I always found it a little curious here that you see such a striking difference in terms of PFS, but really, the OS hazard ratios are still pretty comparable. I think this is actually really important data. Some people, sort of debate the merits of, looking at quality of life across these studies. Admittedly, our metrics aren't perfect. I have a really outstanding fellow, Chris Bergerow, who's really trying to sort of turn some of these metrics around and how we look at quality of life in kidney cancer. Nonetheless, using the metrics that we do have, my interpretation, walking away from the data that we've seen, for instance, from the CLEAR trial so far, mirrors what I've seen in clinical practice. You might derive clinical benefit from the regimen, but in terms of quality of life, not necessarily very different from sunitinib. That was my general takeaway. I'd be curious to know what my colleagues think. In 9ER, and David's going to show you some of the data from Checkmate 214, I would say maybe a more striking improvement in quality of life. And for me, that's a real decision point in terms of how to manage patients with advanced renal cell. I do factor in, the dosing nuances that I'd mentioned, the quality of life data that you're seeing here, and it's really made cabo-nivo my preferred regimen in the upfront setting. I'll quickly mention here, and we can dive into some of these nuances, the management of toxicity with these combination regimens. It's tough if you in the audience are just sort of familiarizing yourself with using some of these combinations. Very important to keep in mind that there is really a set of overlapping potential toxicities with these strategies. You, for instance, may see hepatitis that could be attributable to either one of the two agents, diarrhea that could be attributable to either one of the two. And to really sort of tease that out, I think we've become comfortable with the premise of stopping the TKI for a period of time, seeing if that side effect dissipates to some extent, and then determining whether or not the patient really has a tox attributable to the TKI if it dissipates, or if the toxicity is persistent and worsening, likely secondary to IO. So we're going to get back to this case right now, and I think we're doing well in terms of time, so I'm going to try to probe a little deeply here. So if you see this patient with favorable risk disease with the descriptors noted here, Tian, what are you thinking in terms of frontline management?
Sure. Well, in my mind, favorable risk disease still is less inflammatory and probably more angiogenically driven. So, using all the data that you've just presented so nicely, I certainly think that a TKI-IO combination makes sense, and we would talk through all the different combinations that are approved. And what those the dosing strategies and the actual treatments look like, the Pembro, Pabo-Nivo, and lenvatinib with pembrolizumab. I don't necessarily have a favorite. I think sometimes, in more patients with more disease burden who are more symptomatic, I may choose a Cabo-Nivo approach or a lenvatinib pembrolizumab approach. But for patients who are otherwise not very symptomatic and we're just seeing sort of lung nodules growing on routine scans, those patients, I think, there's still options for axitinib, pembrolizumab, saving the cabozantinib and lenvatinib for later lines of treatment.
Interesting. I always like asking David about this scenario because I find you always have a very unique stance on favorable risk disease. But let's hear your thoughts here.
Unique is one word for it. Yes. So in general, I think it depends on what. Choosing what you do in good risk depends on what the patient's goals are, and it depends on which endpoints you favor the most. I tend to be biased towards long-term endpoints, which we'll talk about in the next scenario, and those are obviously critically important for a person this age. They obviously want extension in survival, but they also want the opportunity to potentially come off treatment if possible, and that's available with CTLA-4, PD-1 in some small number of cases, even with good risk disease. So that's what we would do, that's what we would offer.
But with no further ado, David, I'll turn it over to you.
Thanks, Monty, and I appreciate the invitation, and it's definitely Tian that people are here to see, that's for sure. She's doing a great job. Okay. So going back to that case, and I'm going to argue for dual IO therapy and hopefully not get arrested for recommending something that's not indicated. So, and Monty mentioned this before, this is sort of the other trial. Almost all of the VEGF PD-1 studies had a very similar design. This design was different in that for a couple of reasons. One, it's a pure IO approach with PD-1 and CTLA-4 combination blockade. And it also focused more on intermediate and poor risk, meaning the percent of good risk patients in this trial was limited. Even though it was substantial, it was limited. So here's the data that's been updated. One of the other differences between this data set is it's a year or two ahead of the others. So we have a little bit better sense of what's happening out at 5 years because our patients have reached that point. And what I really would like you guys to do is just sort of focus on the shape of these curves. Let's just talk more art than science here. And this is looking at overall survival, both in the intent to treat population and the intermediate and poor risk, as well as the favorable. And you see the improvement in overall survival, which you see in all of these trials, is not as impressive early on. So if you're focused on early endpoints, certainly VEGF PD-1 wins on those, but the benefits are maintained in overall survival over time. So like true immunotherapy, the data gets better with time. It's like sort of like a wine here. Also, the data at intermediate and poor risk is maintained, and that's where the combination is approved. But take a look at the favorable risk population. I don't want to make too much of this, but right now the curve for the combination of immunotherapy is actually above VEGF TKIs. This is something we suggested might happen. A couple years ago, people thought we were pretty crazy when we suggested it, and it's obviously early and small numbers and all the rest, but I would argue that this is going to be the only curve that is over VEGF alone in good risk patients, okay? And then the question is, then what? Then what do we do? If it turns out that even though Ipi-Nivo is not approved in good risk patients, overall survival is numerically greater, hazard ratio less than 1. We'll see if we get there. We might get there. Also, shapes of the curves here, and this is a key shape. You're looking at flatness here. You're looking at flatness at the tail of the curve, or plateau in these curves for almost all of them. Intent to treat, intermediate and poor, favorable risk, and you see, drooping, even in the good risk population for sunitinib. That same drooping or sagging, which happens to all of us at a certain point, certainly happened to me, is the problem with VEGF PD-1 approaches. That over time, those curves drop off, and that's not what we're seeing with progression-free survival here with CTLA-4 PD-1. This analysis is a little biased, looking at responses at 5 years of follow-up. But essentially this and the next slide show is that if you make it out to 5 years in response, you're likely to stay in response. Maybe not that surprisingly. You can see some of those ongoing responses in about 60% of patients who make it to 5 years. Similarly, looking at the curves, looking at the response outcomes in those long-term survivors, so you're sort of focused here on the patients who are sort of winners, okay, which I think is okay, but is not great. We really, as a field, we need to really focus on everyone, if we're going to make judgments that impact patients, because by focusing on everyone, that gives you the data you need to have that conversation with patients initially. Focusing on how patients do if they make it to 5 years doesn't really help you with that initial clinical decision. One of the interesting stories about immunotherapy is, treatment-related adverse events can be impressive, they can be serious, they can be lifelong, they can even be life-threatening, but most of them happen in the first 6 months. So as you go, particularly as the CTLA-4 is removed from the regimen, the incidence of side effects goes down, and patients generally feel pretty good as they get from months 12 to 18 to 24, because you're not adding new issues for them. And that is sort of shown, as Monty was showing before with the other trials, that's also reflected in some quality of life outcomes, which is quality of life tends to be better, probably not surprisingly, for those patients who are just on single agent PD-1. And we're going to get an update on the quality of life data at this meeting as well. But one of the things that I think is a weakness for the field is the way we look at quality of life data is not consistent across these trials, but also importantly, it stops at a certain point. It often stops a few months after patients stop therapy. And what I think we need to do in future trials is follow quality of life in those patients who are able to live longer off treatment. But we don't really have that information now. I would suggest that it probably is pretty good, but we haven't checked it. So this is what I was getting at before. I mean, we're talking about a 58-year-old person. Obviously overall survival is very important, and we showed those survival curves, showing those patients out at 5 years, which is great. But this is sort of a secondary benefit that you see, particularly with pure IO regimens. We may see it with VEGF PD-1, although this story has not emerged there, but we need to look for it. But in the patients here, this is looking at treatment-free intervals and the so-called swimmer's plots. These are patients who are getting deep responses. This is data that Dr. Motzer presented. Laurence Albigé's also presented this data, looking at patients who are on treatment and then staying when they come off treatment, staying in response. And you see those orange swimmer's lanes of patients who are actually living in a remission of their disease. And if you ask a patient with metastatic disease what they would want the most, is not just long-term survival, but the chance of being alive off treatment so they can go back to their normal routine, go back to work, spending time with friends and family, off side effects, not to mention the effects on cost. And a small percentage of patients with CTLA-4 PD-1 can get this benefit. But this analysis is biased. And because it's biased, I think we should move away from it. Why is it biased? Because it only focuses on the winners. What we need to do as a field is focus on all patients from the beginning of treatment and look at a sort of a comprehensive survival analysis of how do they spend their time, whether it's on protocol treatment, on subsequent treatment, or in what we call treatment-free survival, which is that time between protocol treatment and the next subsequent treatment. So when we do that, we create this new endpoint, which we're calling treatment-free survival, which is looking at all the patients on the Checkmate 214 study. What you're looking at here in the different colors is the different times the patient spent in these different states. So in green, it's the time they spent on treatment. And in this sort of dark, I don't even know what to call it, sort of brownish color, that's the time they spent on subsequent treatment, right? And in pink and purple, that's the treatment-free survival period for all the patients, either in the favorable risk or intermediate and poor or in the entire group. And what do you see when you look at that? I mean, you don't even need to be a statistician to see what it shows, but so survival is greater in all patients, right? In the intermediate and poor patients, but treatment-free survival is twice as long in the intermediate and poor group. And in that favorable risk group, so in this patient right now where ipi/nivo is not yet indicated, it's 3 times as long. So patients are as likely to be alive if they get Sutent versus ipi/nivo, but they're 3 times more likely, based on this analysis, to be alive off treatment. So then it becomes a discussion with the patient. What do you prefer? Do you prefer a VEGF-based regimen where the toxicity and risk might be less, and survival, at least initially, is impressive? Or do you want a chance at not only survival, but being off treatment, taking on extra risk? Because there's no question that when you add CTLA-4 to the mix, you add extra side effects. But by doing this comprehensive analysis, we're looking at everyone, not just the winners, not just the patients who respond, but those patients who fail to respond, those patients who have horrible toxicity. All of that is in a treatment-free survival analysis, and it shows you an added layer of potential benefit, which some patients, not all, might want to strive for. They might want to take on that extra risk of combination immunotherapy as initial therapy, even if they are good risk, like this patient in the case. So this is a survey that Casey Cure ran, looking at this question about what are the patient's perspectives about treatment discontinuation. And as Monty said, some of my beliefs are unique, and you could say odd or outside the lines. This survey shows you we're really not, what I'm talking about is not well accepted by medical oncologists. It's not even well accepted yet by patients. So we have a lot of work to do. So this is the question, and it says current treatments for kidney cancer require continuous therapy. However, research, like what I just described to you, suggests that patients might be able to safely discontinue after a period of time. If your doctor suggested stopping, how do you feel? And so 58% of patients said they'd be anxious. That's a problem for my side of the argument. We need to do much more education. We need to talk to them about the data with treatment-free intervals and treatment-free survival, and we need to try to improve those numbers. And then they asked the question, would you feel safer being able to avoid future side effects? And only 12% chose that. So, we certainly have some work to do, and the Casey Cure, points out that patients are going to be anxious about stopping treatment, at least with diseases like kidney cancer, till we generate more data and educate more patients and clinicians. I think I stopped ahead of schedule.
That's fantastic. Dave, I got to commend you, because every time we come to this discussion around good risk disease, I think you provide a more and more compelling and data-driven argument. So I definitely think that you've really bolstered your argument with a lot of this emerging information from Checkmate 214. So we have a couple of questions from the audience, some related to the previous presentation, some related to this one. But I'm going to start by asking you about how we can get at the right patient for nivo/ipi. Tian had alluded to the fact that perhaps patients who are favorable risk or less inflamed. I think probably the most commonly cited figure in any kidney cancer talk over the past 5 years has been David's McDermott et al. Nature Medicine paper from Emotion 150, a trial of bevatezo versus sunitinib versus atezo, and he did this really beautiful distillation of the genomics, really teasing out an angiogenic signature, an inflammatory signature. Where is all of that now, and how is that kind of moving forward in the kidney cancer clinics?
You're asking me, or
I'm going to ask you. That was your paper.
Oh, great. Yeah, so that work was, certainly exciting to be part of, and the scientists at Genentech that led it, deserve a lot of credit for actually trying to tease out, what are the different subsets of kidney cancer, how do they respond to a variety of different treatments, and they were willing to, put a lot of time and money into that exploration, and they took it a step further in the phase 3 trial, as you guys know. And in the phase 3 trial, which was clinically disappointing, of atezo-bev versus sunitinib, that's not an approved regimen. The translational data, the correlative studies are even more interesting. They were able to subset, they think, kidney cancer into even more cohorts. Based on biology, which in some ways bolstered the early results of Motion 150 by suggesting there's a group that are angio high, the so-called VEGF-driven tumors, as Tian was talking about, that really across trials seem to benefit well from VEGF therapy alone. Whether they get an added benefit from VEGF PD-1, I'm not sure we know, but we certainly are much better now than we were 5 years ago at identifying that VEGF-driven patient. For sure. Whether we can identify a pure IO group, I think we're getting closer. There's obviously multiple groups working with multiple gene signatures to try to get there. And I think if we try hard enough, we can. It's a little more complicated in kidney cancer, as you know, because our tumors are very heterogeneous and our tissue collection is more difficult. But we need to push in this direction. Even if we don't figure out in the metastatic setting, we need it for adjuvant decision-making, for sure. And I think we can get there. But then when you mix VEGF and PD-1, I think coming up with the selection criteria for both biologies is almost impossible, I personally think. Not that you guys shouldn't try to do it, and you're young and energetic, and you should try to figure it out. But I think it's going to be hard because you're essentially trying to take two of the major biologies that drive kidney cancer, you're fusing the therapy together. It's going to be hard to say which is the group that needs both drugs, But have at it. I hope you guys can sort it out. And Tian, I'd like to hear what you think on this.
If I could add to that, certainly, I think having the landscape and subtyping of kidney cancer has been really important. And until we do the prospective patient selection, treatment, and figuring out the right options and randomizing them to the different combinations that we have now, I don't think we'll get there, right? So the retrospective analyses are not going to teach us enough. So if we can use the information we've learned from all the emotion trials and use that biology to push forward into our prospective trials, I think that's where we're going.
I think the tricky thing, to build on what Tian was saying, is I completely agree with her that the good risk group is probably that VEGF-driven group and probably benefits from VEGF. The question is, how much does PD-1 add in that setting? Or would you be just as well off doing the sequence of the two? Because the sequence clearly improves survival, but what does the combo provide? And I think we were hoping in the early days that blocking VEGF would enhance the immune response to the tumor, and we'd see more of a prolonged immune effect, so that those curves would look flatter. For example, we'd be able to stop treatment in more patients. And to a certain extent, we may see that, like the CR rate, for example, which you guys highlighted, is certainly impressive. But will we be able to, did we really succeed in what we were trying to do? I'm not sure that the data is showing us that yet.
In the favorable risk population, right, if we're not extending, so that the cohorts are very similar in terms of overall survival, so sort of piggybacking on your prior point of what are the patient's goals, and if it's time off treatment or just less toxicity over time, I think immunotherapy approaches might be, pure immunotherapy approaches might be better for that particular patient in terms of selection. I don't think your views are heresy, David. It's certainly a small population, but if we talk through their goals and all the treatment options, there are some patients who say, Ipi-Nivo might make sense for them, right, in that upfront setting. And if we don't know which exactly will ultimately win out, then one after another may prove just as good as using both upfront. The other thing I worry about with our VEGF-IO combinations early and using both mechanisms is that we run out of options at some point.
Right.
Because these patients are seeing 3, 4, 5 lines of treatment, and we're always searching for what are they resistant to, and how can I sequence the next line of therapy.
Right, no question.
So I've got a zinger for you here, David. Okay, this is a good one. So this patient comes into your clinic,
Yes,
okay,
sir.
with favorable risk disease, as it says here on the slide, and says, I got McDermott et al. Nature Medicine, I got my sequencing done,
Yep.
and I fall into this angiogenic category. Would you still suggest that patient receive Nivo-Ipi up front?
Well, okay, so that's a world we don't live in right now.
Let's
but I
say,
would
yeah.
imagine
Well,
that
I live in Los
RNA,
Angeles.
I can
Anything can
imagine
happen.
that RNA sequencing in the next 3 to 5 years might be part of, say, foundation testing. So what you're describing is not inconceivable. That said, there's still going to be some overlap. These biologies are not pure. So even though that in a good risk person, they might be very much VEGF driven, there's still going to be a subset of those patients that are going to get some benefit from IO. And knowing that they're good risk, they don't have symptoms, they may end up on VEGF, but we can get them there. You're not worried about missing an opportunity in that patient. So I would still go for trying to get a long-term benefit, trying to get a remission with immune therapy, knowing that I can salvage that patient for sure with Cabo. I'm not going to miss the window, or with TiVo, or with lenvatinib. Any of these drugs are going to work after Ipi-Nivo fails. As long as you don't stick on the PD-1 for too long, I think you can get most of those patients there. But you're probably right that they would probably do just as well with VEGF.
So I know that seems like a, perhaps somewhat implausible scenario, okay, but Tian, it actually leads to a very, I think, practical question, which is, now there are some investigators who are taking a stab at this question. How can we use McDermott et al. Nature Medicine 2018? Was it 2018?
Yes, sir.
To actually treat my patients, right? So Brian Rini, I give him a lot of credit for this. He's designed a study called the OPTIC protocol, in which patients are going to be treated either with Nivo-Ipi or Cabo-Nivo. And I believe he's actually doing sequencing up front, characterizing their profile based on the emotion data, and he has some hypotheses based around the profile that results. Is it worth it for us as investigators to tackle that approach, or should we just move on to other questions, looking at new targets, et cetera? What do you think, Tian?
Well, I personally think that unless we actually do that careful prospective selection and randomizing or selecting and saying you're inflamed, we need to use pure immunotherapy targets, until we actually do those prospective studies, we're not going to move forward as a field for molecular selection, right? So I agree that we can put efforts toward novel targets and mechanisms of resistance and trying to overcome, but we also should place some emphasis on Brian's trial with prospective molecular selection so that we can actually answer these questions for the field.
And what do you think, David? You and Brian and I were all good friends. You expressed a little bit of, perhaps, nihilism about the study. What do you think?
No, so those, as I agree with Tian, we need to do more of those studies. They need to be bigger. So that would be my only concern with that trial,
Okay.
with the size of the trial. But the reason it's critically important is even if we never figure out what to do with metastatic patients based on a biopsy, because the tumors by that point are too complex, we need this data to move to the adjuvant setting, because there we've got new therapies, we're going to try to build on them, but we're going to be building on them in patients who are probably, some of whom are probably already cured. And then that risk benefit that Tien showed is really out of whack if we're causing side effects in those patients who probably didn't have cancer. So this work will educate that work and improve outcomes for patients.
I like that. I mean, I think that that's a very logical argument about how, some of this information might permeate into adjuvant therapy. So I'm going to keep just heading right through this and have a discussion around something that's really come up quite a bit in our Q&A. We're going to walk through now what we would do beyond frontline treatment. So, I'm just going to highlight some of the data sets that I find, somewhat interesting in this particular context. Things that we've done with existing regimens to sort of tinker with dosing. Some of the questions in the Q&A here reflect what we would do to sort of optimize dose for patients. Could we start at lower doses of a TKI, for instance? And this study really took a stab at that question. So this is a randomized phase 2 study. It was actually an FDA-mandated trial that compared a dose of lenvatinib at 14 milligrams with everolimus at 5 milligrams to lenvatinib at 18 milligrams with everolimus at 5 milligrams. And of course, Len-18 is what we use in the clinic in the second-line setting. So this particular study, I think, asked a very relevant clinical question. It's a 300-patient study, which is not a small trial, but maybe not big enough to address the primary endpoint, which was a non-inferiority design based around toxicity. We ultimately didn't see any significant difference in toxicity using 18 milligrams versus 14 milligrams. If you look at these curves and if you really try to pick them apart, you might see some subtle differences as well that really sort of seem to suggest that lenvatinib 18 is still the way to go. You might compromise efficacy to some extent by going with the 14 milligram dosing. Overall survival, again, is quite similar between the two arms. One study that I think we need to really sort of focus on as kidney cancer community, and some of the questions in the Q&A poll here really reflect new targeted therapy options, is this one. This is the data from the TiVo-3 trial. David was one of the co-chairs of this particular study. It's now published in the Lancet Oncology, and we as a group have been doing a lot to sort of put out some additional data from this particular trial. And this was a study that really addresses what I think is an unmet need in advanced kidney cancer. This takes individuals who have had 2 or 3 prior lines of treatment and randomizes them to receive tivozanib or sorafenib. Now, this study was powered to demonstrate an improvement in progression-free survival with tivozanib over sorafenib, and it certainly did that. And as you can see from these Kaplan-Meier curves here, again, this isn't, the frontline setting. These are patients that have gotten 2 or 3 prior treatments. I was actually quite impressed that if you look at sort of the tail of this curve, if you will, there's a subset of patients on tivozanib that are really deriving persistent benefit. My experience in the clinic with this regimen sort of mirrors what you see in the top right-hand side with these tornado plots. And while you can see that things like hypertension and fatigue are somewhat comparable, there's a lot less in those really bothersome day-to-day toxicities like diarrhea, hand-foot syndrome, nausea, vomiting. This has really been true to my experience in the clinic, and I've heard this from many other colleagues as well. I encourage you to take a look at a poster that me and David and other co-authors are presenting on Saturday at the meeting. And this really takes what you see in that Kaplan-Meier curve in the top left and extends the duration out almost twofold to the 4-year mark. And one thing that you'll appreciate in looking at that data, and right now it's in tabular format in the abstract, is that, again, that benefit with tivozanib really holds over time. So, Cabo-Nivo, as I'd mentioned, tends to be my upfront regimen. I'm actually really sort of sequencing tivozanib further and further up in line of therapy. This is a summary of the data from the trial. Updated results show response rate more than double with tivozanib over sorafenib. And just as highlighted in that tornado plot there really seems to be a better tolerability profile with this agent over sorafenib. And just to reiterate at the bottom there, this agent is approved for relapsed or refractory advanced kidney cancer after 2 or more prior systemic therapies. Now, what about combination therapies? We really focused a lot of our discussion at the outset and reflecting on frontline regimens on Cabo-Nivo, lenvatinib pembrolizumab, axi-pembro. There are other possibilities here with emerging TKIs and other immune therapy partners. So this is the data for tivozanib and nivolumab in combination. This was run by Laurence Albige and is now published in the Annals of Oncology. My fellow Luis in the audience wrote a very nice commentary on this in the Annals of Oncology. But this was a 25-patient study that demonstrated, I think, an impressive partial response rate, 52%, CR rate of 4%, and you can see the Kaplan-Meier curves off there to the right. Maybe the most important thing about this trial is it's now morphed into a phase 3 clinical trial called the TiNivo-2 study, and this is going to be presented in the Trials in Progress on Saturday. I encourage you to look at the design. This is really going to get at what David had alluded to earlier, this data void area. If we've treated a patient with immune therapy in the frontline setting, would they potentially benefit from immunotherapy as second or third line? So now we're going to get to what I think may be the most exciting part of this lecture today, although I think we've had a lot of great conversations. And we're going to have Dr. Zhang talk about, sort of the morphing frontline setting, and Dr. McDermott's going to highlight some of the opportunities in the refractory setting. So Tian, I'll turn it over to you first.
Great, thank you, Monty. All right, so next generation first-line trials in metastatic renal cell carcinoma. This is a topic that's near and dear to my heart as I think through our trial portfolios nearly every day. And we've really come quite a ways, I think, from our sunitinib-controlled trials in the last 5-6 years to now benchmarking and controlling our phase 3 trials using immunotherapy-based combinations. So you see that control cohort on the bottom. These are all patients with clear cell metastatic measurable disease and no prior systemic therapies going on to treatment. They're often stratified based on IMDC risk score because we know how important that is in terms of outcomes, the region of the world, and performance status. And these patients are randomized now to either the control immunotherapy-based combination or, we've highlighted some of these studies here for you, nivolumab, cabozantinib, and an adaptive design based on pedigree, a trial that we lead in the Alliance Cooperative Group. There's a triplet study using belzutifan, lenvatinib, and pembrolizumab, benchmarked on lenvatinib with pembrolizumab. That's now open and accruing in the US. And then there's a triplet study that has already finished accrual, the COSMIC-313 study with ipilimumab, nivolumab, and cabozantinib. And that recently completed accrual, and so we're awaiting results from COSMIC-313. And then finally, the other cooperative group study, the SWOG study that's ongoing, is PROBE, and this is asking a very different question of timing of consolidated nephrectomy after patients start their immunotherapy regimens. But I think all very important questions to ask as we start to think beyond the doublets in the frontline setting and also thinking about patients with de novo metastatic disease and the outcomes with consolidated nephrectomy. And so all of these patients are generally treated until disease progression, unacceptable toxicities, or a response endpoint. And I would point out that in pedigree, there is a secondary endpoint of 1-year complete responses with prospective discontinuation. And I believe it is the first study with a prospective response assessed discontinuation endpoint to Dr. McDermott's point of thinking through patients who are able to stop treatment and come off treatment with treatment-free survival intervals. We'll be able to study that population more in depth. We also have another trial that's completed and thinking about the IL-2 pathway. So thinking through our past cytokine successes with high-dose IL-2 in the 1990s and early 2000s, reformulating IL-2 in a pegylated form, the bempeg-galdesleukin or Nectar-214. We saw an objective response rate of 71% with this combination with nivolumab in the PIVOT-02 study, and it was generally well tolerated. The PIVOT-09 study now has finished accruals. This is a phase 3 study in the first-line metastatic setting, benchmarked against sunitinib or cabozantinib, and with the combination of nivolumab and bempeg-galdesleukin. So I think all of us are looking forward to seeing the results of this study that really harnesses what interleukin-2 can do for our patients. We're also excited to think through more HIF-2 alpha inhibition. We mentioned earlier the triplet study in the frontline setting, but HIF-2 alpha and the biology here was certainly elucidated within the Bill Kalin's lab, and thinking and belzutifan as a molecule developed within Peloton has come through UT Southwestern with very nice disease responses. So a phase 1-2 study showed that belzutifan alone, given at 120 milligrams once daily for these patients, had an objective response rate of 25% with 14 patients having confirmed partial responses, and you see the waterfall plot highlighted here. Of these patients who had responses, the majority had responses for more than 6 months, and with most common toxicities being anemia and hypoxia, but generally very well tolerated in our clinical experiences. Belzutifan also has shown good disease control and responses in patients who are pretreated with prior VEGF inhibition for patients with renal cell carcinoma in combination with cabozantinib. And the preliminary analysis from cohort 2 of the phase 2 study with patients having prior immunotherapy and less than 2 or fewer prior therapies for metastatic cancer showed 86.5, at least some reduction in target lesion sizes. And so this formulates the basis for the ongoing phase 3 study that is randomizing patients to either belzutifan or everolimus in the post-treatment, post-first-line treatment setting. And we look forward, and this trial is currently enrolling, and we certainly await those results to see the effect of belzutifan in that highly refractory space. And the COSMIC-02 study, I think, was quite a well-designed study in terms of thinking about combination approaches. David alluded to earlier about thinking about cabozantinib and atezolizumab in the post-treatment setting, treatment refractory setting. And COSMIC-021 showed in clear cell disease very nice objective responses. Over 50% of patients had partial responses or better, as you see on the left, and in the right, a good amount of, about a third of patients or so having partial responses or better in the non-clear cell renal cell carcinoma space. And so certainly this sets up the CONTACT-03 study, which is a phase 3 study in this refractory space for patients who are previously treated and have immunotherapy refractory disease, now being randomized to either cabozantinib at 60 milligrams daily or the combination of cabozantinib with atezolizumab. And certainly this will give us much more data, I think, for the post-IO treated patient in terms of thinking about sequential therapies and adding in the layer of PD-L1 blockade. All right, and I think we'll turn it back over to you, Monty.
Sure. You know what I'm going to do is, this is such great fodder for discussion. I'm going to put this slide up here that you showed us, Tian. And I love the pedigree approach, which is your approach, this sort of adaptive design, right? So, patient goes on to frontline treatment in sort of this risk-adapted fashion. They go on to receive potentially additional cabozantinib on top of their nivo, in the sort of quasi-second-line setting, if you will, right? My question to you, and I'll pose this to either you, Tian, or David, is, with these other trials, how much is too much? I'm just looking at that, lenvatinib, belzutifan, pembrolizumab, nivo, cabo, ipi. Is it too much for patients to tolerate? What do you think, Tian?
It's a lot, and certainly we'll see whether there are some overlapping toxicities in that frontline space and whether the toxicities are worth, right, the upfront benefit from these triplets. As you alluded to, so pedigree certainly is almost a triplet in sequential form, ipi-nivo followed by the potential for nivo-cabo in randomization. And I am a little biased because I treat lots of patients on pedigree now. But and I think when we're thinking about people who need triplets in the frontline setting, in my mind, they may be patients who have more symptomatic disease, who need some early control, but also thinking, hopefully, for that durable tail of the curve with our immunotherapy combinations. I'd love to hear David's thoughts about this too.
Yeah, and if I can add just a little context, is, David, I think part of the general approach, as I synthesize, what you told us, is that, you're looking to sort of potentially even, minimize the, sort of downstream therapy for the patient, get them to these treatment-free intervals. This seems to be a bit of a different premise. What do you think?
Yeah, this is the kitchen sink premise.
Yeah.
For at least trials 2 and 3. I think I agree with Tian. Both pedigree and probe are important and ask clinically relevant questions that we deal with a lot in the clinic. It's going to be good to have prospective data on some of those questions because we're always sort of tinkering without data right now. I think, but for the belzutifan trial and the ipi-nivo-cabo trial, there are issues with how much is too much, but also, what is the evidence that these drugs add to one another? So, for example, if you ask the question, how much does HIF inhibition add to VEGF blockade? Right now, there's no randomized evidence that suggests it adds anything. But we have this phase 3 trial. So that's, to me, I would have done the randomized trial of VEGF HIF versus VEGF first. But that's not what we're getting. And I think it's up to us as investigators to insist on some of this information before we support some of these large trials, because that's 1,400 patients. We need to ask questions that are and confirm results, based on solid preliminary data. I don't think we have it, at least with that triplet at the moment.
Great response. And I definitely sort of am thinking along the same lines there in many respects. David, I know you've thought a lot about, sort of the design of these trials and so forth. And, these have conventional endpoints, these triplet therapy trials, PFS and OS. The bar is so high now,
Yep.
right? You think about the Len-Pembro response rate of 71%. How much higher can we get, right, in this particular context? And are we going to look at, a trial where we hit, a response rate of 80% with the triplet combination and say that that's a win, Are there different ways that we can start thinking about de-escalating therapy? Are there trials you think that we need to do to sort of see if we can pare down the extent of treatment that we're using?
Well, I think Tien's trial, the Pedigree trial, gives us a way forward, stopping treatment sooner. That's one way to improve treatment-free survival, is to stop the treatment. And stopping it in patients who are in response is something we should explore more in randomized ways. The problem with that is a lot of patients don't want to be randomized off drug when they're responding and their side effects are under control. But someone needs to do that trial of how much is necessary. Because, for example, if we're adding 3 and 4 drugs and we're seeing improved overall survival and we're able to create more remissions, sort of like a lymphoma, like an R-CHOP model, I think we'd all say, great, this is where we need to be. But if we're just raising the bar incrementally around response rate and PFS, and OS is no different, then people are going to push back and say, this is too, the costs are not worth the benefits. Certain places are not going to pay for it. And that brings me to the COSMIC trial. Like, you can almost guess the result of that trial right now. That trial should, unless there's a toxicity signal, it almost certainly will meet its primary endpoint, that early endpoint of improved PFS. But is OS going to be in the, less than 1? Maybe, but probably not if patients can cross over to get VEGF. And then what? Do you give a triplet that doesn't have an OS benefit? Some people will say yes, and particularly payers will say not so fast.
Yeah, the toxicity and the cost certainly in those triplets are bothersome.
Right, so we need to move the field in the right direction, and part of that is we need to insist on the right trials being done and the right endpoints being looked at.
I wonder too, with all these novel, immune targets coming out, TIGIT, LAG3, et cetera, what if we were to find a way to replicate the response rates, the PFS, the OS that we're seeing here, and match what we're seeing with contemporary regimens, but maybe bring down toxicity? Is there a path forward for those regimens, or are they going to have to demonstrate an improvement over this already very high bar of progression-free survival, response rate, overall survival? What do you think? Yeah.
Oh, it's a great question, and I do hope we get there with our novel targets and that are promising. And we won't know until we try and actually do the studies. As of this moment, I think we have sufficient phase 1, phase 2 data. None of them are quite coming up against our standard of care approaches in the frontline setting. I hope those trials are under development, and that we will be able to use some of these novel targets going forward. But I agree with you, until we see that synergistic effect and really add to the frontline responses. How much of an increment above 70% objective responses, right, is enough to offset the toxicities of these potential triplets. I think that's still to be determined, whether that's clinically meaningful to use these triplets in the upfront setting.
Sure, sure. David, what do you think? I mean, you're really kind of at the forefront of a lot of these immunotherapy trials, and let's say it was, sort of a triplet of, PD-1, I'll just make this up, LAG-3 and TIGIT that looked really outstanding.
Great idea.
What's that?
Great idea, Monty.
Great. What if it looked outstanding in the clinic, but you weren't quite sure that it would necessarily supersede, the PFS, OS, and response rate that you see? Is there a path forward for that if we can produce similar but not superior results?
Right. Many good questions within that question. I think if you look at melanoma, which I also do, there are ways. It's almost easier to build on pure IO regimens than it is these hybrid regimens. So for example, PD-1 plus LAG-3 is superior to PD-1 in advanced melanoma. So that LAG-3 blockade could be explored in kidney cancer in a pure IO regimen. If you added that to a VEGF PD-1 regimen, the benefit might get lost, and improving those early endpoints with IO regimens is really hard, particularly when targeted therapy is the comparator arm. So building on IO, comparing it to IO, I think makes sense. But the weakest part of my endpoint argument, and there were probably many weak points, but the weakest point from a clinical development point is it takes years for the endpoints that I focus on to emerge. And both patients, investigators, and companies, they want early endpoints. They want an early look. And coming up with a endpoint that is sort of predicts what's going to happen at the tail is important for the entire field of immuno-oncology. Otherwise, a lot of these novel agents are just going nowhere, because they're never going to be able to win on those early endpoints that we focus on so much.
Okay, great. So a lot of questions here in the prompt. I think we're going to take this program right until the buzzer at 8:30, if that's okay. So one question, and I'll sort of try to phrase this in the context of a theoretical patient, okay? 58-year-old patient who, approaches you in the clinic and says, Doc, I really want lenvatinib and pembrolizumab up front, okay? Metastatic disease with, let's say, mild symptoms, painful shoulder metastasis, multiple pulmonary mets. He says, I want to get lenvatinib pembrolizumab, but I'm a little bit scared of the toxicity. What do you say I just start at 10 milligrams instead of 20? What do you think, Tian?
Oh, it's a good question. And, certainly overcoming that resistance or early fear of toxicity is one of the challenges we face in selecting early frontline therapies. I would personally be amenable to it, and let's start you low and go high if you tolerate it well. If the alternative is not starting at all, right? So I'd rather get some drug into patients than nothing at all. So if that's the compromise that we're setting in order to get him some effect of lenvatinib, I'm okay with that, to say, hey, but on the trial, we're all cognizant on the trial and the efficacy that we saw, the 70% objective responses was at 20% starting. So our goal is to get you there to 20%, 20 milligrams. But if that's our bar to get you started on some drug, I'd rather, let's get that drug into you and get you seeing what the side effects look like. And there are people who tolerate it well and will escalate, and then there are people who don't. And that's the non-purist in me that will sort of work with patients and meet them at their point.
So you'd allow for some flexibility in dosing. David, how about you in that upfront setting?
Yeah, no, I agree. I mean, the trials are not nimble enough to allow for that, but in reality, we shouldn't be treating patients at the MTD of these drugs. We should treat them at the minimum effective dose, which, find their dose, what Tian said, and starting low and getting up to their most tolerable dose is much more likely to keep them on the drug longer term and get that disease control. Otherwise, if you overshoot, if you go to what the trial said, you're likely to stop. I guess in the CLEAR trial, maybe up to a third of patients had to have a dose reduction or interruption. And sometimes patients don't want to try it again, even though you know as a clinician that you could get away with a lower dose if they tried it and all. Some patients back off. I think Tien's approach makes a lot of sense.
Yeah. I don't know. I tend to be maybe a little bit more dogmatic about dosing in the frontline setting. I think that, when we're talking to our colleagues in the community who are starting to use these regimens, I think they've really got to make sure that when they apply a regimen, they know that 70% response rate with len/pembro might be compromised if you shave down the dose, or those endpoints that you're targeting might be mitigated to some extent. So in that scenario, what I've generally tried to do is sort of counsel the patient, if they're really fixated on adverse effects, maybe go with what I perceive to be a better tolerated regimen up front, like cabo-nivo. I've tried to sort of steer the conversation a little bit in that direction. It's a complicated issue, though, isn't it? Another thing that's sort of come up here, and this is maybe a sort of clinical experience question. I've worked with some of the HIF-2 inhibitors that are currently in pipeline right now, but have not actually treated a patient as yet with belzutifan. Can you guys share your experiences with belzutifan? How was it from the standpoint of tolerability? Give folks here a sense of the boots on the ground impression of the drug. David, have you?
I've had a handful of patients on belzutifan for the VHL indication, and truthfully, they've tolerated it very well. As a clinician, I'm a bit concerned and monitoring carefully for hypoxia, and I think that is a symptom and sign that patients are sensitive to, and so we've been bringing them back frequently to monitor, and these patients have actually been tolerating it very well. I haven't noticed any cytopenias yet, so generally, very well tolerated in my hands.
I would agree. I think it's one of the cleanest drugs that's been in clinical development for kidney cancer ever. And when a patient goes from whatever, drug X to belzutifan, they usually feel better. Very narrow list of toxicities. Tien mentioned one of the more difficult ones, which is on target, and patients can get hypoxic. Usually that responds very quickly when you stop the treatment, but that can be an intimidating side effect in the clinic. But anemia is another one, which is also on target because you're lowering erythropoietin levels when you block the HIF transcription factor, but also very fixable anemia. You can give them erythropoietin and they come right up, and there's not a whole lot else, which gives it a nice single agent toxicity profile plus the ability to combine. So I think we know the answer to, can you combine HIF with a variety of other things? And the answer is yes, which is good. What we don't know is how much it adds to those things, because we only have single, arm trials. We need more randomized trials to see how much it adds.
Well said. And I'll just kind of bring this home with something that was just announced yesterday, I think, on clinicaltrials.gov. This is a randomized phase 3 study in the adjuvant setting, and I think we all probably saw something like this coming, looking at pembrolizumab plus or minus belzutifan. Tien, what do you think? Is it too early for us to be pushing belzutifan into the adjuvant setting? Do you think it's a reasonable study design?
Sure, it's certainly a study that's underway, and whether we're ready for it or not, it's coming. So I agree with David. I haven't seen the preclinical synergistic effect or immunomodulatory effect of belzutifan. I'd love to see that data if it's there. And see, but I think the trial is already ongoing in terms of development, and it's going to sort of shape our next adjuvant landscape.
And what do you think, David? I mean, we've had this whole discussion around de-escalation, making sure that we've got these synergistic effects demonstrated to our level of satisfaction. Is it too early? Yeah,
the development of this trial just shows you, if you haven't known it already, how little people listen to me. Meaning, it could be a great idea, right?
Yeah.
Because we know the HIF inhibitor is actually more active in the early setting than it is late. If you look at the data in patients with von Hippel-Lindau syndrome, which are very prone to renal tumors that are small, the data there is ridiculously good in controlling those tumors, which in some ways may be similar to small renal masses or early kidney cancer. So there's certainly a rationale for HIF inhibition early. But if you ask the question, does HIF inhibition add anything to immune therapy in any context, mouse, human, the answer is we don't know.
Yeah.
I mean, the reason Tien doesn't know is because nobody knows.
Right.
But
Right.
we'll
No,
do the
fair enough.
trial anyway, and let's see. Well, should be interesting.
Excellent. No, this has been a really great discussion. I think I'll probably close with just an additional question or two. This is something that I've sort of been stewing over, and it's reflected in some of the questions here in the Q&A. So let's say we take my standard patient in the clinic. So they up front for metastatic disease will get cabo-nivo. And I started to use more tivozanib right after that in the second line setting, right? When they get to third line, right? Let's say this patient is still reasonably fit, but has certain exclusions from clinical trials. I don't know, maybe their hemoglobin's a touch too low, or, actually to make it more salient to what I want to discuss, let's say they have some, newly evolving brain mets that put them out of window for a study. Okay, so you can't answer with a clinical trial for this one.
Okay, good.
Good. So in that patient, would you go for lenvatinib everolimus? Would you try to expose them perhaps to axitinib as third-line treatment? Or would you try to get compassionate use belzutifan for that patient? I've heard of this happening, in practices nowadays. What are your thoughts? Dave? Oh, Tien, go for it.
Oh, well, to be honest, I would, if good functional status, I think there's a bit more data for lenvatinib everolimus in that setting. If they were more frail and we were thinking, maybe a HIF inhibitor might be helpful, then certainly thinking about belzutifan and trying to get the off-label use could be an option. But we have a standard of care option, and lenvatinib everolimus is a fine choice for fit, healthy patients.
Yeah, what do you think, David?
No, I would agree. I think in that patient, you can argue that person needs a response. So you go with the combo if they can tolerate it. It's more likely to give them a response. I think when we look at this is a prediction, which is probably worthless, the randomized phase 3 of belzutifan versus everolimus, you would expect it to be positive, but my guess is the activity in that setting, which is this setting, is going to be less, because if patients who failed 2 prior VEGFs are probably less likely to be sensitive to a HIF inhibitor. Going back to the story Tien was talking about before, is like, are these VEGF-driven tumors, yes or no? Well, a VEGF-driven tumor is also a HIF-driven tumor. Third line, less activity of HIF, I would predict.
Okay, interesting.
And come back in 2027 and you can
Talk it over.
That was right. Talk it over.
David, excellent. No, I appreciate that. Any other agents that we haven't talked about today, and we're in the closing minute here, that you're excited about, that you want our folks in the audience to just get a glimpse of? Tien?
I think thinking through mechanisms of resistance as patients go beyond frontline combination approaches is really important. I'd love to see treatments that increase tumor antigen expression, for example, come through, and really thinking through, these mechanisms that might affect and how do we re-engage the immune system and reactivate it when people have these slow-growing resistance patterns. And so, in my mind, anything that might push the field forward in those settings as people get 2, 3, 4 lines of treatment will be helpful.
David, how about you?
Building on that, I completely agree. I think there's a lot we can learn from tumors, particularly resistant specimens, about what to do next. What are the targets we need to hit? We're also developing, the larger field is developing engineered immune cells in that setting that are showing some promise in other tumor types. So CAR T cells could make sense to the proper patient. I know you're exploring that, Monty. TIL therapy, where you take the immune cells from the tumor and you energize them in the lab and give them back. There's clear evidence of efficacy both in melanoma but also in lung cancer with that kind of approach. So for the highly motivated patient, hopefully that will be an option at the next 2024 maybe. We should explore those options of sort of escalating therapy in some ways like we do with testicular cancer in the right patient, being more aggressive for those patients with those newer treatments that are showing promise elsewhere.
Field is just changing so rapidly in advanced kidney cancer, and I really want to thank you, Tien, and you, David, for helping summarize it today.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/TRX860. This educational activity is supported through medical education grants from Aveo Pharmaceuticals Incorporated, Bristol Myers Squibb, Eisai Incorporated, Exelixis Incorporated, and Merck & Company Incorporated.